Thank you. Thank you, first of all, everyone, for sticking around. After the sweets and the very eloquent Oxford professor talking about ethics, and just before you get your drinks, you get another talk on ethics, but this time it's a panel discussion. Well, actually, I think the treat is coming now. Or at least we have a good session planned here. As we have, and I can say this as a tall person, I'm the smallest person on the stage, looking at the impressive background of these three guests. So first of all, here from left to right, I have Alessandro Curioni, who's an IBM Fellow, Vice President for Europe and Director at IBM Research. Next to him is Farzana, Dr. Farzana Rahman. She's a consultant radiologist at UCLH, sorry. And she was a clinical advisor on data and digital strategy lead for the NHS Digital. And she now has a role with the Academy of Medical Royal Colleges, which we'll talk about a bit later. And last but certainly not least, Professor Effy Vayena. She has an impressive background, like I said. She works now at the Institute of Translational Medicine, previously worked at Harvard Medical School, which now works in Zurich, at the Health Ethics and Policy Lab. So I think there are some different backgrounds on the stage to talk about ethics. We have three topics to talk about, but I think we'll go in between of them while we go. So I think starting off, I would like to ask you, Farzana, what are you doing working for the Royal Academy? I heard you're doing something on writing a guideline on AI. What does that entail? And maybe for the second question, what's the biggest challenge you have, which you've spotted for physicians?
Mm-hmm. So the Academy is producing a report which is articulating the clinical concerns and just areas to be raised regarding the ethical use of AI in healthcare. And the document aims to kind of articulate, specifically from a very clinician-centered perspective, the kind of issues and areas that probably I don't think we'll have answers to, but I think we certainly need to think about as policymakers, regulators, and then just citizens generally. Coming to your second question about the biggest issue, I think an important issue is understanding liability, and it's not really one that I've got to the bottom of either. So when we talk about AI, then we kind of know that we're not really at a stage where we're going to have independent use of AI. So then we come to where does the liability sit when a clinician uses AI to help inform their decision making? And that's where it begins to get quite complex. People now say that, well, that's just, there isn't really that much, you're just consulting. But actually from a medical legal perspective, if I were to ask you for some advice, then you wouldn't be liable. If I were to ask you advice about a patient and you saw that patient, you would be liable. And there is a train of thought kind of in legal circles that as soon as you have AI that incorporates data from wearables or from medical records, then you begin to go into this gray area of patient contact and patient interaction. And under most jurisdictions, then potentially that could be liable, and we just have no regulation and no legislation about it. So I think that's a very interesting area.
Very interesting indeed. So from a more academic perspective, what's your view on this issue, on this liability issue?
Well, I of course agree that liability is a big question, but for me this is a downstream question. I think, of course, at the end, people are worried if they're going to go to court, if they're going to be punished if something goes wrong. But I think there is the concern and the thinking before that, which is really, what is the right thing to do here? And once we sort this part out, then we could figure out, okay, then we will distribute responsibility in this way, and we'll legislate in a way that then we know how, once we get to court, who is going to get to do what. So I think in these developments, what's important, and I think Luciano earlier explained that very beautifully, is to figure out what is these different responsibilities that we're going to have? How do we get to define them? in these systems that we have. And of course, there's going to be these various principles that we saw that will help us get to that. I'm not saying it's easy, and I'm not saying it's easier than sorting out liability, but I think it's the work that has to be before we get to liability.
Issue. Yeah. So of course, IBM has been in the news. Now you're not working for the commercial side, but what's your perspective on this?
So look, I do think that this is so important that we get it right. And as she was saying, going to the start, it is very important that we establish trust. We as a company, in AI for healthcare, but in general, right, we are really trying to promote this concept that AI and the professionals has to form a partnership, okay? And AI should help the professional to take the best decision, but the final decision still stay in the professional, okay? And this is not only important, you know, to make it clear what we are speaking about. It is also important to establish a much better machine-human interaction that we need to have when we move forward. What is a strong responsibility of the people, and not only companies, but companies, academic world, that are developing the technology behind? And I do think that today you have discussed this several times, right? We need to make sure that the technology, and by the way, it's not a single algorithm, right, can be trusted, so as to be secure, need preserve privacy, do everything state of the art in order that that happen. We need that the artificial intelligence models as explainable as possible. We have done step in this direction. We need to do more. Eventually, you know, when you say what does it mean explainable, we cannot pretend that it's more explainable than the knowledge that is out in the world. But at that level, why the machine suggests something, right? And we need also eventually to make sure that we take away all the bad biases from the engines that the machine has. This is our responsibility. And this is something that we need to do if we want to establish this trust.
Bad biases suggest something like good biases. How does that work? Because is that true? Is there something like a good bias?
Yeah, there are some good biases, right? For example, if you develop a model that has to help to give a possible treatment for prostate cancer that is a male type of disease, right? You want that is biased towards males, right? Not include something that could be only a bad bias, so that is a positive bias, right? There are other biases that are bad biases that come simply by the fact that models are used trained on experience and eventually on data that come from the past, so can accumulate also bad way to do things, right? That simply come from the past. And you know, AI models, if you are not create a model based on the data that you have, so if the data are biased, you get a biased model. So developing technology that is able to detect these biases and eventually correct in the model, in the data, become very, very important.
Okay, thank you. So Effy, how do you look at this? I mean, I'm of course looking here at a lot of pharmaceutical companies in the room. I did a bit of myself in pharmacy research, phase 1 research. We tend to include younger, male, or even middle-aged men that have not a lot of comorbidities in these trials. So bias has been around for quite a while, right? We've been treating maybe even whole large groups of women without them ever being included in one of these trials. So what's your position on this?
Well, that's true. This has been happening, and I think we're not proud of it. So I don't think that we should say because it's been happening, we're going to perpetuate that. We know, and finally we came to agree, yes, that we women take those drugs that have been tested on men primarily. Or a lot of other things that have been going on. So the question is how this opportunity that we have now with the technology can be put in place not to perpetuate those wrongs, but rather to help us correct some of those. So the fact that we did it the wrong way before, it's no justification whatsoever. And we had also a learning curve there, and we had trouble correcting it. Now it is an opportunity, which brings me to a question that I think is crucial. You mentioned trust before, and I think, again, in the medical and the clinical setting, what we've been trying for a long time to do is things that we introduce into the clinic, they go through some rigorous testing and processing so we can trust them if they got there. Of course, is this a perfect system? No. Did we introduce to the clinical setting things that they were not ideal? Yes. Should we continue doing that? No. But what I think is important here, and to me this is an unknown, maybe you guys have a different response to this, is what is it? What are our criteria? What is the kind of evidence that we need to produce in order to say, yes, this product is ready for the clinic and we can trust it once it's there? I think for me, and that comes to the bias question, how much bias or how little or what kind can we allow ourselves? Because also in pharmaceutical development, in drug development, we've allowed ourselves margins of error, right? So what is that? How do we set the bar here in order for the product that comes in, and I as a patient come in and you will prescribe it to me or use it to treat me, then I can say, okay, through that, now I trust that system and you continue trusting you using it for my care. So for me, that's another realm that I think we need to pay attention to.
So who's deciding here? What do patients think about this? Do they get to think anything about this? And what do doctors know about this? I mean, maybe a good question for you.
So I think questions like this force us to kind of think beyond just AI and really just look at our own medical practice. And so a good example of this is lots of algorithms use clinical decisions that we've made as committees, guidelines. But I don't know how much those have gone through a rigorous panel of assessing bias. So there was an interesting paper in JAMA where two people put forward that there was software that recognized melanoma very, very well. But the data that had been submitted, which was all open source, so nothing really to do with the people who picked using that data, was all of white skin. And we know that people with darker skin have worse outcomes from melanoma, partly because of type, but often because of misdiagnosis. So then that begins to really scratch the surface of how are we practicing medicine? What bias do we have in our decision making and in the data that we're collecting? Because, as Effy said, these kind of things will only, technology has the potential just to amplify them. And if we really want to bring trust, then probably they're the kind of things as clinicians we now need to start looking at, because unfortunately in medicine, optimal outcomes doesn't always mean fairness or equity, and we've just seen that.
So how would you envision building this trust? What kind of things are you going to offer physicians to bridge that divide?
Look, I do think that, as they've just said, simply that the fact that we are having this discussion, realizing that, for example, some of these biases were present in the past, but people were not scary so much. And the advent of these technologies, because we look at the technology, push a change in the full healthcare practice, it is already a good point and good value that we should recognize, right? The other thing that I want to mention, it is fundamentally important that while we develop this technology, we are doing in the most transparent way possible. We need to make sure that people knows what we are doing, how we build the systems, eventually which data are going to use, so that if we don't get it right for any reason, others can correct us. So the transparency of the full things, in my opinion, is a very, very important thing, and is something that also as a company, right, we have decided to follow as principle. It's not easy, right? Require time, iteration, but that is a principle that we would like to follow.
So open sourcing is one of those venues?
Also.
And how about, I mean, the training level? I mean, we were just discussing, sometimes need to explain younger doctors what the accuracy of some of our tests are, and actually they don't know. And you can ask them whole day, what's the accuracy of your doing here? And they don't know. So what tools do doctors need to be able to, even if we get a disclaimer of this data was used here, you open source millions of lines of code, how can we assess what's going on there? What do we need? What are we missing?
So one of the ideas that's been put forward is it's probably going to be impractical to have every single doctor be able to unpick an algorithm from IBM. Whether we need to invest in training a subset of clinicians who kind of overlap between computer science and medicine, and to see whether that kind of panel can then give recommendations and break down information for other colleagues. I mean, you know, that skill set is very, very, very specific, so would require, I think, a lot of investment.
All right. Now we've been going on, and I think we can continue for quite a while here, but I see some red signs here, which means that I need to open up the discussion to you. Who would want to go first, asking a question to one of the members of the panel, or to the whole panel? Can someone get a microphone here to the gentleman over here? Right here. Sir, if you can state your name and your question, please.
I'm Jonathan Shapiro. I'm independent these days. I've been around the NHS for a very long time. The elephant in the room seems to me risk appetite and how one programs AI in terms of risk. Medicine isn't exact. We all take risks. Hospital doctors take fewer risks than GPs. There isn't a right answer. Who's going to take responsibility for the risk and how do we calibrate it? If you look at technology in hospitals at the moment, the machine will beep when it exceeds something. It tends to get ignored because it's too risk averse. How do we calibrate risk?
Effy.
It's the elephant in the room.
Yes.
And that's, I think, the big question. I go back to what was said earlier, that this is the exact kind of thing that I don't think one single entity or profession is going to answer. This is the moment where I think it is the clinicians together with the people who develop those technologies, together also with the payers, together with the healthcare system. We in the past have been doing this with less complicated, complex technology, a bit siloed. I am the company developing the technology, then it's priced this way, then I have to introduce it in the clinic, then the clinicians have to take their view on that. And I think this, again, I see it as an opportunity to sit down together and think what kind of risk, what degree of risk we're prepared to take together, right? Not just because the company is going to have an excessive profit from that, but the clinicians are going to get lost, or they're going to have a burnout from whatever ways they're going to use that. We've seen that as well, or the payers will decide something different. So for me, and that is an imperfect answer, but in what I think is a very complex question, is that possible solution is through deciding the acceptable risk together.
All right.
Further to that, there's an interesting model put forward about a concept called enterprise liability in legal circles, which is the idea, exactly kind of a legal model for this kind of grouping of risk, whereby you create an enterprise, which is a legal entity. So it would be, let's say, the hospital, your doctors, your AI, and you would then, the way that a hospital would assume a degree of liability and you would take out insurance for your doctors, you would kind of then begin to build a model like that. And then if there was to be a consequence of action, that then you would then approach that enterprise. So that's been put forward. It would need to be legislated for.
And I do think when you speak about the risk, right, you are speaking about risk related to an outcome, okay? And this, of course, is the sum of different type of risk. And I do think that enabling this discussion, also educating both sides, so we, the developers, the company, the medical doctors, and them, us, right, on how the outcome come out, will help again to develop better this partnership that I was telling you before. And that will make sure also that we take the risk in the right way. Again, from a company side, I do think that we will need to make sure that the risks associated to certain decision, to certain data breach, to certain privacy breach are almost going to zero, right? Then there is the risk of the decision that is something that require additional discussion.
Okay. I'm afraid we're out of time, but please ask questions after this session. Thank you. Thank you for this discussion. I think could have gone on for hours, but thank you very much for this. Thank you.
I think that
And thank you very much for your question.